My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Paape,
And you're listening to the Fix Podcast.
your source for all things implant dentistry.
Yeah, so I'm curious too, just to kind of simply lay out a basis of, what the old versus new is, what is ideal and what isn't. Can we just kind of like briefly illustrate, what are the ideal mechanical properties of the classic sub, the classic, I think you're,
Do you mind if I show a model?
yeah, not at all.
Yeah,
Yes,
go
it's
ahead.
all videos.
All
Please, yeah.
So this is, bear with me here, guys. This is one of my stereolithic models
Okay.
that was done on my cat, sent to the lab in Colorado. And you can see we're loading the lateral ramus here.
Mhm.
We're loading the symphysis. We've got a meso bar that comes out of the ascending ramus here. Canine. There's only 4 posts.
Yeah.
Very first sub I did was at Mish, and Carl says, well, we've got to spread the load out. We need 9 posts, and we'll talk about coatings. We're going to coat it with HA. And my mentor and Wynn, Dr. Littlejohn, said, don't do that. And I said, I got to. I got to deliver it at Mish. And so we did. And the guy was a classmate of mine who was a pedodontist. It was his father. And he smoked like a train, like 3 packs a day. And I said, you can't smoke for 2 weeks. And we're in Dearborn, Michigan. And I get finished with the surgery. And I don't even think I got to close it because it was over 2 hours. It's one of these shit show type surgeries. And it happens to all of us, And so I'm in the didactic part. And they finally dismiss him. And he's out in the parking lot. And I go out to say goodbye to him. And he's leaning up against the car. And he's already smoked a cigarette.
See ya.
Incision line comes open. A lot of the stuff dehisces. I become an expert at removing struts. I become an expert at soft tissue grafting. Life Core was just coming out with Alloderm at the time. Dr. Littlejohn loved perio, and he was doing a lot of work, and I was learning a lot of work and doing a lot of work with him. And we grafted this poor man for years. And I think it lasted 15 years. He actually passed away with the implant. But it went from 9 posts, I think, down to 5 by the time, he passed away. So, even Carl Misch, as brilliant as he was, and I think he's one of the smartest implantologists in our era, he had things that he did that were mistakes. And, I guess my big message to all the young docs that are wanting to jump right in the middle of this PSI, just like we all wanted to get into zygos and pterygoids and nasal implants. And it's like a trophy up on your wall back here, I did this case. I'm going to show it here and I'm going to show it there. It's on TikTok, whatever, Instagram. And that's all great, but you do your reps, be careful, because we're in a very litigious society. And back when I was learning, it wasn't like it is now, and patients were more forgiving, more understanding, and, be careful. But, this implant here, if you look at it, has a meso bar. And everybody wants to do screw retained teeth now. They want Nobel compliant MUAs coming out. They don't see the value of the meso bar. Well, this implant actually would bond to bone. It would actually be covered with bone in certain cases, or it'd be encapsulated with soft tissue, that ligament that Bob James talked about. So it allowed for a little bit of movement, but the meso bar kept all the struts together. If you had one side go bad, and sometimes they did, you'd literally cut it behind the canine strut, take that segment out, reline the overdenture on that area. Patient lived with 2/3 of their implant, and they never missed a lick. And they could eat anything they wanted, and these were the happiest patients in the world. We come forward to the new PSI designs.
Yeah.
Here we go, and you can see how much wider everything is, and it's all it's depending on screws and that piriform rib. I love it that it's engaging the zygoma, but like this one's in 2 pieces. Everybody wants to do it in 2 pieces. Well, you're missing the nasal spine, which is going to be the thickest bone in your palate. This one has palatal coverage. I looked at the design on one of our chats rooms just yesterday, and there was no palatal coverage, and what going against in the maxilla is the fact that there's membranous bone, alveolar bone, very porous bone, very poor quality bone, and you have to have enough resistance to your occlusal loading to prevent that thing from settling over the decades. And just because it's titanium, just because it's all this technology, just because you throw a bunch of screws in it, uh, doesn't mean it's better, and doesn't mean it's going to resist that occlusal force that you put on it. People want to put zirconia teeth on it. Lenny Linkow, he actually put a study out. I think it was 1998, where he had done 600 maxillary subs prior to describing the problems with maxillary subs. He did an additional 300 maxillary subs, and he followed his success rate and went from 60% to like 70, 80%. Okay, with these changes. And he did palatal coverage, canine eminence. He would even go over the hammer knot into that area. And, you know, there's a lot of things that have been tried and a lot of errors that we saw from the past that we're replicating all those errors today.
Mm.
And, you know, somebody said, well, it's titanium, it's bonded to bone, it's better. Where's the proof? Where's the studies? And let's say we make this mandibular implant now and make it out of titanium, and we seat it. And instead of doing a meso bar, we do MUAs.
Mhm.
All right. So now we've got an MUA prosthetic, Zerk, with 4, desk screws, Vortex, Badger. You take your choice, but 4 button screws holding this in. What happens if this segment or this segment or this segment come loose from the bottom?
See ya.
It's lost.
See ya.
Okay.
Yeah.
But if you've got a meso
Yeah,
bar,
yeah, you can segment.
we've got 80 years of this sucker working. So even if it's titanium or chrome, cobalt, molybdenum, we know that it can survive in that suspensory ligament. So the meso bar has its place.
Mhm.
Now, are we working with designs now where we're putting MUAs on top of a meso bar on the lower? Absolutely.
Mhm.
So that we can have a digital workflow, because overdentures are a pain in the butt to make. The labs, there's very few labs that still make them, and getting the records for it and having to transport analog models and stuff. I hate analog now. I mean, I'm literally been 100% digital since 2020.
Mhm.
We bought 3-minute scanners, tabletop scanners, iCams, everything. And so, I'm all in on digital. But when you have to go backwards analog, there's a place for it. And like even casting the implants, we did a digital STL and we printed it out, but we cast it. There's some advantages and disadvantages to casting as well, But the big thing here is technology is wonderful, and I'm envious of you young men, to where the next 20 years are going to lead for your careers. As I phase out of the game and y'all go forward, you're going to remember in this minute saying, wow, look at all what we're able to do now. AI designs it and push a button, they print it out, and push another button, and they mill the MUAs and they polish it, and boom, I've got teeth.
Yeah.
Uh, but I think it's very. I'll just be nice. I just knowing these doctors, studying from these doctors, looking at all their hard, good, honest work. I think we're really missing the boat if we don't know our history. There's who was it said, if you don't know history, you're doomed to
You repeat
repeat
it.
it.
Yeah.
Okay, and it could be more true in what we're doing right now. And I love some of these young doctors that are promoting the PSI, and I've worked with them and I've done demonstration surgeries with them, but I do not agree with them pushing this out and promoting it even over quad zygotes. I mean, I really feel like a maxillary subperiosteal should be a rescue implant, and mandibular subperiosteal, a whole different ballgame. I mean,
Mhm.
I got 100 of them over 35 years now, and it's been damn near 100% success. We've got studies from Dorsey Moore at UMKC. There were over 20 done over 18 years. They were placed by the oral surgery residents, restored by the prosthodontists, prosthetic residents, 100% success rate. We had John Mendeschetti was doing a study on HA coating of implants. And I just, in my research study, how he placed 20 and had 100% success rate at 10 years,
Mm.
maxillary subs. And these are all the classic designs. They're all cast. Some were digital records. Some were two-stage surgery. Even Bernardo, as many as he's done, he was like, segmentation is a problem. Or the sinus. You can't segment that out accurately, and you've got these big defects. And if you go back to Linkow's 1998 article on the deficiencies of maxillary subperiosteals, he discusses that very problem, and he came up with a solution. He put his support over the sinus on a little finger off the main part of the sub, so that if it gets exposed, you only had to cut it in one place and pull it out.
Mm.
So
Make it more retrievable was the solution.
exactly. So
Yeah.
I just designed. I don't have that. I don't have the actual sub with me, but this is a maxillary sub that we designed that we were going to deliver 2 months ago at Full Arch Masters sub course that we did, one of Ron Dunlop's patients. And, I was able to take the DICOM data, and I put one of my screws in the Z point,
Nice.
Super
and I
cool.
love it. Z point selling.
Yeah, I know.
Classic.
Just for David.
We just did that one.
He was our last
Yeah,
guest.
I know you just did. I listened to it. So, that's one of my spots. And, when I was doing and I'll go ahead and name it, it's Bone Easy. And I did a demonstration surgery with Bernardo, and I did a podcast with him, Full Arch Masters, several years back. And we were putting the implant screws around the nose, super thin bone, and we had rescue screws. And as I'm tightening them down, it's like, I'm not getting anything here. They're not fixating. I'm like, how much good are these doing? And then I'm thinking in my mind, okay, when this patient starts functioning on this and loading this, how much resistance are we going to get? So, there's a right way and a wrong way to make a maxillary sub, but I don't have the answers. I've been doing this 39 years, and I'm not about to sit here and say, oh, I've got the answer for these. I have a really good idea where it should be loaded and how it should be loaded and how it should be designed. But, for a young doctor that's been out less than 5 years and doesn't have a lot of reps under his belt, doesn't have good support from an ENT or an oral surgeon like I do, you start having complications on these. You got some splaining to do, and you don't have a lot of literature to back you up,
Mm-hmm.
And I just think that we should really back up and be very careful with what we're seeing promoted, especially by the companies
Mhm.
and even some of the KOLs, and just this should be something that should be a last resort, but it's a beautiful last resort, and it can work great, okay, especially on the mandible. But the maxilla, it's a complete different animal.
Yeah. So can we just to kind of briefly summarize, what are the main things that make such a big difference between the predictability of a lower and an upper sub? I mean, what I've heard are, you have a totally different quality of bone in the upper. The upper has much more complex anatomy. It can be very difficult to create a passive prosthesis there. Anything else there that can kind of summarize why there's such a disparity between the predictability of both?
We'll take a right off the slide from the lecture from Linkow.
Mm.
Inadequate bone support, inadequate cortical bone. You've got alveolar bone. You have lateral sinus walls.
Mhm.
You have poor tissue quality, especially over the sinus. You have mucosa,
Yeah.
penetration, cone beam segmentation issues, and you've got revision difficulties. So, Linkow's features that are critical to sub. And I wasn't a big Lenny Linkow fan at all. He's from New York. I'm from Arkansas. He talks funny. I talk funny. He's very bombastic. I'm a little less,
Yeah.
but after reading this article, I'm like, damn it. I wish I'd spent more time with this man because he's really was brilliant, you know. And I hear people, oh, well, this is link all this and that. They don't do the deep dive in this. They don't read this stuff.
Right.
They don't study it. They don't understand it. But first thing, low, dense cortical bone. Okay, there's not much up there. You know, what do you have?
Mm.
You know, you got
Eggshells.
zygo,
Yeah.
eggshells. You know, adequate model, direct impression or cone beam CT. One of the companies I'm working with, JD, right now, they want a helical scan of the maxilla. I said, guys, it's a no-go for 99% of the dentists. They don't want to take them to the hospital. They want to use their iCAD or their Ray scan or whatever, VETTEC. And they're like, well, we can segment it better. We can clean that up better. I'm like, well, okay, you know, maybe we'll send them to an imaging center and we'll get a helical CT, you know. Engage the nasal, palatal nasal spine and canine eminence, okay? He didn't have zygoma in there, you know, but we know zygoma is available. We're all there now. Maximize buccal keratinized tissue. He would probably love our lingual, you know, scarf grafting technique there.
Pedicle
Buccal flat
scarf.
pad. He would love that. This is all not really something that was being done back then. A lightweight frame. Okay, you look at these frames, you know, and the stuff that's been done now, they're massive. Now this one's thin, but a lot of them are really thick, and they got right angles. You know, I mean, when you compare it to something like this, I mean, look how thin this is.
Yeah.
And you've got lots of places for the periosteum to reattach. Okay, so lightweight frame. You want to minimize your crossover struts, and I actually had one guy early that was lecturing on these. He says, yeah, they didn't used to recess these things in the bone, and we recess our crossover struts in the bone. I'm like, first of all, you know, I was taught to recess it on my very first one in 1990. And I start looking through the literature, and I mean, it's been done since the 70s, recessed, you know, on the bone. So, you know, that's where I say be careful who you listen to. Do your own deep dive. You know, you really need to be responsible for knowing your game. And that's why I felt like when this was a required implant for ABOI, I was the last, you know, when I got mine in 90, I had to have a sub. And they dropped it because the oral surgeons didn't believe in them, periodontists didn't believe in them, prosthodontists didn't believe in them. You know, it's just a bunch of dumb GPs in the Southeast doing them, you know. And so you've got this whole generation that has zero exposure to subs because it wasn't a requirement. And I get that. But my whole thing was at the time was like, we still need to know about these. We still need to teach it. We still need to let these people know how to manage the complications on this. And so I spent a lot of time teaching how to manage subperiosteal complications, that people call. So crossover struts, minimum of 2 millimeters wide. So you look at this thing and, you know, it's 3-4 millimeters wide going across, and we're across the ridge 3 times. Whereas, you know, you look at a crossover strut here and, you know, it's 2 millimeters and it's recessed. So there's a big difference there. And then Lenny, he was big on his palatal strap, but history shows that those palatal straps, they fenestrated, you know. So I think that, you know, it's just a big thing. And then with the prosthetics, you know, he was like no tissue engagement, removable, 0-degree teeth over opposing dentures. If there were natural teeth on the opposing, 10-degree maximum on your occlusion, and minimize the anterior guidance. So one of the big concepts with subs was, you know, the occlusal table on these is flat. If you look at the teeth, the buccal cusp was the most prominent. There was actually a cutter bar in the original ones. And, you know, I went through the era in the 2000s of the extreme makeover, and I'm having these ladies spend $25,000 on an implant and $5,000 on a denture, and they got a metal bar, and I don't like that. So I literally had Root making Empress teeth color match, you know, without the metal bar before these became available. But so today with occlusion, you know, everybody wants to do zirconia teeth. They want to use Exocad. You know, a lot of people are using 20-degree. They're doing group function, anterior guidance, all this stuff. But with the sub, you just want it to slide without any lateral excursion, without any anterior guidance. Now, I can't give you a study. I can't give you any literature. It's all anecdotal, or you want to say it's clinical, whatever. But in practice, by doing this, and I was told this 38 years ago by my mentor who had been doing them 20 years. So they've been restored this way for 58 years successfully. Okay. And I told you I had several hundred implants come into my clinic from Dr. Joe when he passed, Dr. Harris when he passed, Dr. Cremeen when he retired. And so these patients didn't have a home. They didn't have anybody that understood sub. So I would take care of all these patients. And, my goal was to get them to the end game, have them die with their implant. And we were successful. I never took one of those guys' subs out. I might have to take a posterior strut out or something, but the vast majority, they get a little permucosal infection on the ascending ramen strut, put them on a round of Keflex 500 TID for 10 days. And 99% of the time, that maxillary denture or teeth had worn and they were locked in. And when they go in protrusive, they had anterior guidance. And when they go to lateral, they couldn't because they were locked in. So all we do is we replace the teeth. We call it a retread on the upper, or we just take some composite or try it at the time and just fill in the groove. And they come back 2 weeks and they were fine.
Wow.
So those concepts, these important things that I learned from my mentors, I think it's things that we need to take forward to the PSI world, and I don't know how being integrated to bone is going to work. Is it going to work like a root form implant? Maybe, maybe not. But what happens if it's not bonded to bone? Or what happens if it debonds? Well, we know this worked. And so, what you want to do is have as atraumatic occlusion as you can on these. And so, that's the wonderful thing about implantology. I mean, it's the full game. It's the occlusion, it's the soft tissue, it's the maintenance and recare. I've got hygienist that's been here with 22 years. She sees 8 implant patients a day, and maintains this stuff. And I mean, she knows what's going on as well as I do. I walk in, she says, Dr. J, we got to get a retread here. We got to do this here. Boom, 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 But it's things like that that you need to go into knowing before you get into this world of subperiosteal implants.
Yeah, I definitely think there's a big wave going along with it now, and I think that in full arch, it's like we've kind of developed this linear mentality of how one develops, right? It's like you're going to go into singles, you're going to do some overdentures, you're going to do your all-in-4. Once you've done enough of that, you got to do your pterygoids. Now you're going to get into zygos, and maybe you're going to get into customs, or maybe you're going to do one of those first and some other ascending order. It's just this idea that after you've spent a certain amount of time, you just need to go to the next step and start doing more and more advanced stuff, and I agree with you that we need to be looking back as much as we're looking forward, if not more, to learn from some of these things, because history does repeat itself. A lot of these things have been tried before. We've learned a lot of things, and not only have some of the things that went wrong been forgotten, but some of the good stuff has been forgotten too. And to not see that moving forward is concerning. And I think you're raising some really important points that people should really be considering if they're looking into getting into that customized implant world, because I think right now it's difficult. When I talk to a lot of U.S. dentists that have considered them, they see a lot of logistical barriers, medical legal barriers into getting into custom subs. Not really sure how.
Your own practice going to cover you.
Yeah, right.
I mean,
it's a brave new world now.
yeah, it's a whole new world. I mean, it's like zygos. I mean, I think my first zygo course was at Picos, and they were doing the original Nobel through the sinus spline, and I'm an archer. I mean, I can put an implant if I want it someplace I could do it. That's just my gift from God.
Yeah.
And so I'm nailing all these implants, but I'm like, there's no way in hell I'm doing this in my office. And then when we got the extra maxillary, and these things, I'm like, okay, I could do that. And I go to Vichy's office and we do a case there and it goes great. And I come home and I got 5 cases lined up. And I think I got 2 of them successfully completed. The other 3 were just complete disasters.
Yeah.
And I'm like, I got to have more reps. So I go to Brazil to Salvoni's course and I get in 8 reps and I realize what I was doing wrong. And now, an archer again, with zygos. But, I mean, I put off doing zygos for over 10 years until the technique had modified enough that it was predictable
Yeah.
and safe to do.
Yeah.
And I guess that's kind of my message with subs. You know, we want to do a mandibular sub, let's get on it, you know. But with these maxillaries, you need to be extremely selective with the patient, extremely selective with your manufacturer. And, you know, if you've got a mentor or somebody that can be there with you and help you with this and walk you through this, do it. You know, there's not a lot of us out there, you know, but just be careful and don't get yourself in hot water.
Yeah.
Try to get a trophy on your wall.
Absolutely. I think the trophy hunting is an issue. I think we've all been.
We're all guilty of it. I was.
Exactly. No one.
I mean, my credentials, you know, I wanted to prove myself and I really haven't ever really even advertised that I'm a diplomat or a fellow. I mean, it's on my website, but I never put it in my print media. It's never on my television stuff, you know. Uh, I just didn't want to step on toes, you know, here, and it wasn't necessary. I know it's necessary for doctors that are in big cities, with, you know, lots and lots of competition. But you know, now, you know, it's just one of those things, you know.
Yeah. No, I understand. So let's say someone, is an experienced full art surgeon. They've done a lot of their homework. They've done some zygos. They've done good work and they've spent some time on this. They've got a lot of recare under their belt, but now they want to start, tackling some customized subs. What are some principles that they should be looking for when they're considering different labs that do it, different types of designs? We've talked a little bit about the sleekness of the struts. We talked a little bit about surface treatment. What are some, boxes we should be checking as we're kind of trying to vet out different sources?
So first thing, you know, you've got to have your prosthetics nailed down, okay?
Yeah.
And you know, that was one of the issues Nate and I came up with some of these cases that we were doing for other doctors. Were getting the prosthesis seated properly, uh, getting a DICOM image with that seated properly, uh, getting an STL of that prosthetic, stitching all that together so that when you do design your implant, your MUAs or your meso bar and everything fit within that prosthesis.
Yeah.
Okay. And, you know, even my analog guy kind of messed up on one of our implants and he got the occlusal plane wrong on it, you know? So we had to come back in and digitally alter the maxilla
Mhm.
and can everything up a little bit to make a little freeway space in there. So first thing is you've got to have a dialed in prosthetic design. Okay. And then you've got to be able to communicate that to it. You know, on your patient selection, I mean, it's got to be a resort bridge. It's not, I don't think that you should be trying to take out teeth, cut bone, cut crossover strut segments and pop it in. It's just, you know, one miracle at a time, you know, one step at a time. So you need to pick that carefully. And then, you know, it's just like in any implant practice, start out with what's known or more predictable. You want to do them mandible. But don't do this stuff that you see where there's three permucosal abutment struts from the second molar to the first premolar, and you know, big, thick, wide crossover struts, whether they're recessed or not, with 90-degree angles out into mucosa, which are all going to, you know, to hiss. And so that's where understanding design concepts and even talking to these manufacturers. You know, I've got one I'm working with right now, and when I saw the design, I was like, wow, this guy knows what he's doing, you know? And if we could just change the workmanship of the implant itself just a little bit, you know, because he was hitting all the hotbeds. He had the zygo, he went around and got your past the tuberosity, and he got the mid palatal suture. I mean, he hit all the hot pop spots on that, and he had 4 permucosal posts. So you know there are some people out there designing, but then you know, you've got all these other countries with all these other designers, and you know they've got an engineer or a biotech kid that's doing it, and you know they're brilliant with the software, they're brilliant with their concept, they're brilliant with their finite element analysis, but you know when it comes back to what's biologically compatible in that patient's mouth,
Yeah.
What's the tissue going to tolerate? And that, I guess that's the biggest thing is you need to have quality bone for this thing to resist the forces of occlusion, and you have to have quality tissue to protect it, you know? And then you've got to have occlusion that's atraumatic. So you have to be able to find somebody who can do all that. And unfortunately, I haven't found that person yet.
Yeah,
Okay.
I'm curious too, right? So, I mean, I'm thinking about, what is good quality bone for a patient that needs some maxillary subperiosteal? Like, how do you really assess that? I mean, these are very atrophic people, right? I mean, it's not going to be the best
So,
situation.
Nate spends over 24 hours doing a design. You know, I probably spent 5 or 6 hours picking out Z points and, the zygoma, mid palatal suture, and saying, okay, here's where we're going to load. Okay. But, I'm doing the views through the lateral sinus wall. I'm doing the views through the sinus, and I've got, 0.5 millimeter bone. Well, that's not going to resist anything,
Yeah.
you know? I mean, the only hope you have is to spread that load out. But there's not, I can't give you a black and white answer. It's going to be on a case by case deal.
I understand.
And, what are you putting on it for occlusion? Are you going anatomic teeth? Are you doing centric line teeth? Are you doing zirconia? Are you doing a plastic teeth or PMMA teeth? I mean, there's a lot of factors to this. And, I've been doing it 35 years. I don't have all the answers, especially when it comes to the maxilla. Now, if you want a mandibular sub, I can say, here's what you did, okay? And here's what to look out for.
So in your opinion, you think that if somebody's getting into, some of the more difficult maxillary cases, you first would do remote anchorage, zygos, quad zygos, and save any kind of sub, customized sub situation to like the patient that even that isn't going to work for.
So, in my lectures, it's funny. I didn't do palatal approach before 2020. Okay. So I learned palatal approach, and it pissed me off because I really enjoyed doing zygo.
There's just so much.
I'm super doing
There's so much you can do.
And my zygo count went down like 90% from palatal approach and transnasals and pterygoids and stuff. It was like, damn it, But with getting back, I mean, with these, pick your cases. Start out with the mandible, and then on the maxillas, just be extremely careful. Pick your patient, have a relationship with that person, and be very honest. Things could go south. I mean, I've got a lady right now in my clinic that was done by a very good surgeon in Arkansas and restored by a very good prosthodontist in Arkansas, and they've both been very open, sent me everything, and she relocated to my area. And she's got bilateral fistulas into the sinus. Huge, huge exposure. Food's getting up there. They're infected. I've referred her out to an ENT that I work with. He's trying to get her cleaned up. I've got an oral surgeon. My oral surgeon's the next door neighbor's a great guy. And we're like, how are we going to fix this lady? Because when this all comes out, she's obturator.
Yeah.
And there's nothing to hold it in, And she's in her 80s. Her health is failing. And it's horrible. So the devastation from these can be very, very bad.
Yeah.
And, so you asked me, are zygos first choice and these others? I think that for the maxilla, I think the sub should be the last choice. And you had on here, what do you think is controversial? That's one of the things. Because, there's going to be other people that say zygos are wrought with failure, it's complications and infection. And yeah, I've had all those myself, and zygos, I respect, extremely respect those. And I do realize there are complications. But when a zygo goes south, I feel like the revision on that is easier.
Yeah.
And in one of the threads, we were talking about subs this last 2 days. Dan Holtzclaw comes in. He goes, I got 22 references that support zygos. How many do you have that support maxillary subperiosteals? And most of the case studies that I see that I've been able to research, and I even got the high dollar chat
Yeah.
GTP and started researching it. It's like they're 2 years,
Yeah.
26 months, 36 months. And I got docs, well, I've got some out 5 years. I'm like, okay, let's see what they look like in 10 or 15. Because, if you own your own practice and you stay in business long, I mean, it's like, I've been here 39 years and I literally have 30-plus-year-old subs in my practice,
Yeah.
And, you see this stuff come in and again. You really don't want to see this stuff going bad. And it's not a practice builder.
Right.
And, I like to sleep at night.